right? For suppose if the individual is having a syncopal attack and it is of non-cardiac origin, right? And it is of unexplained origin, right? And it is of unexplained origin, okay? So syncope of non-cardiac, unexplained origin, that too in younger individuals, they have excellent prognosis, right? They have the excellent prognosis. And in these patients, the life expectancy is unaffected. Right? In these patients, the life expectancy is unaffected. That is about the syncope. How will be the prognosis if the individual is having non-cardiac and unexplained origin? And by contrast, the syncope due to cardiac cause, right? So what was the cardiac causes for syncope that I was discussing? The cardiac causes for the syncope, right? Either structural heart disease or primary arrhythmia disorder that is associated with increased risk of sudden cardiac death. Okay. So this cardiac cause, whatever might be, either it might be, right? Either it might be a structural heart disease, right? Or it might be a primary arrhythmic disorder, right? Or a primary arrhythmic disorder. This is associated with increased risk of sudden cardiac death. And in these individuals with cardiac causes for syncopal attack, mortality rate is very high, right? Similarly, the mortality rate is increased in individuals with syncope due to orthostatic hypotension also, okay? So even in patients with, right, even in patients with orthostatic hypotension, right, in these individuals also presenting with the syncopal attack, the mortality rate is increased, right? Mortality rate is increased, okay? And the mortality rate is increased in individuals with syncope due to orthostatic hypotension, and this is related to age of the individual, and this is related to, right? And this is related to comorbid conditions, right? This is related to comorbid conditions, okay? So these are like in case of orthostatic hypotension, what are the comorbid conditions that will be responsible for the mortality? So this is the entire list, right? Where the individual having chest pain suggesting coronary ischemia in a patient with orthostatic hypotension, features of congestive heart failure, valvular diseases, mainly aortic stenosis, moderate or severe structural cardiac disease like cardiomyopathies. Then the ECG features suggestive of the ischemia, mainly the acute coronary syndrome, and history of ventricular arrhythmias, that is VT or VF. And if the QT interval is prolonged more than 500 milliseconds, that will predispose to polymorphic ventricular tachycardia. And if there is a sick sinus syndrome, that is repetitive sinoatrial block or the sinus pauses, and if the individual is having persistent bradycardia, or a patient with orthostatic hypotension having bi or trifascicular block or the intraventricular conduction delay with QRS duration of more than 120 milliseconds, then atrial fibrillation, non-sustained ventricular tachycardia, family history of sudden death, pre-excitation syndromes, Brugada pattern on the ECG, palpitations at the time of syncopal attack, syncope at rest or during the exercise. So these are all the associated comorbid conditions which will increase the mortality rate in individuals with syncope due to the orthostatic hypotension, right? So the likelihood of hospitalization and mortality risk are higher in older adults as well, okay? So even in the older adults, there is likelihood of the hospitalization right? There is likelihood of the hospitalization, and at the same time, there is also right, and at the same time, there is also increased mortality risk as well.